think another key point is that in addition to this being born out of necessity, we've had a relaxation and a liberalization of a lot of the rules that have come from CMS, the Centers for Medicare and Medicaid Services, have made telemedicine really instantly much easier, and many insurers and state legislatures have made accommodations to lower the barriers that I think were probably largely unnecessary, artificial, obstructive, and protectionist. But this has at least changed that temporarily. So it makes it easier, but we've also had the points that you raised that this is not the right tool for every patient, that this may be very well suited for patients who are coming in for a routine visit, particularly for patients who we know and have established relationships with, who have been on a pill-based therapy and doing well for 8 or 12 or 14 months, and we're just checking in. They may have gotten their labs and scans previously at some other place, and we can review those without it really deteriorating the interaction by doing it virtually, and that's particularly appealing if people are a distance away. But it's not perfect. It's not feasible for people who are getting treatments and they're going to the infusion center. It really makes sense to, they can't easily do that at home. There's a few options that are starting to pop up about people getting home-based infusions, but that's not widespread. And I would also point that out that you know, as Ben had mentioned, some patients don't find this the easiest thing. That it depends on what systems we're using, but the user interface is not always totally seamless, and a lot of people have limitations because they're just not comfortable with the technology. They may not have the hardware or the internet connectivity. So we can never presume that to be universally available. And I would say it's a good tool for some of our patients, probably many, at least temporarily, but it's definitely not the perfect tool for every patient now or in the future. Any other, what are your thoughts about that, and what proportion of patients it's really going to be a good tool for, and whether this is very temporary or something that you think will be of sustained utility beyond social distancing mandates?
Yeah, I would say that I think that this situation, this climate has put into high relief all of us getting out our retrospectoscopes to think about how many patients do we really need in our office. That exactly what you alluded to. These patients who are on targeted therapies, who are getting labs every 6 to 8 weeks, how often do we really need to see them? And is this a medium and a way that we can connect with folks where they don't need to come in once we get over this climate? Will it alter how we practice medicine for some of our patients, particularly the ones who are on genotype-directed therapies or targeted therapies or even immunotherapy or even in a surveillance mode, post-curative intent therapy? So I think that this will change some of our perceptions on how to best manage some of these patients in which we don't need to see them every 8 to 12 weeks, or we can get labs at a local LabCorp and review them and have a telemedicine visit. So I think it will change some of the way that we practice medicine on down the line.
How about you, Jared? I'm not hearing you. Let's see. You may be muted.
Sorry, I was muted. One of the realities of COVID-19 and video conferencing, whether with patients or for a purpose of this, is children screaming in the background. So I was muted while not talking. That's been a reality with patient calls. I've had kids come into the screen, you know, when I'm trying to talk to a patient, because this is just life, right? Normally I go into the office to do everything, to separate that and make it impossible. And that's just going to happen sometimes in this era. And frankly, most of my patients have found it hilarious and therapeutic. And it's one of the ways to expand back. But I thought you might not want to listen to the kids screaming. So at any rate, now that I've taken the obligatory 2 minutes, I'll get back to your question, continuing that theme. I think it's a little different for our established patients versus the distant consult patient. So for my established patients, many of them are quite poor and have limited social support, come from the other side of the state because we're the state hospital. You know, I think for a long time I've had an interest in virtual care for these folks because it's better care for them. If I don't want my patient having to save up to come see me. That's a problem. And so I think this will forever alter care in limiting visits for those patients. And as well, I'm having more frequent contact with some of my patients with the lowered barrier. They don't have to come all the way in to have a visit, and that's a productive change that I think will continue. The other side of my practice is the consultative practice, and I know both of you share this, where a large proportion of your patients are one-off consults where the question is, am I doing the right thing? Or the variant of it, do you have a trial for me? My mentor used to, probably still does, call this Baruch atah chemo. So for the non-Jews listening to this, that's blessed be the chemo. You know, you're doing the right thing and you can continue doing it. And the others that say, you know, I want to travel to you, but only if you have something unique to offer me that I can't get locally, some unique procedure, some unique trial, something that should travel. And I would love to be able to serve those patients without making them travel. The truth is, when I see these tertiary or quaternary consults where they're coming in for this sort of question, I usually pre-prep my note. I review all of the outside records, I review the scans, I review the pathology, and I write out my plan before I even meet the person face to face, with the understanding that, of course, as I talk to them, if I learn something that's going to change it, and listening to them and examining in that face-to-face interaction, that of course I'm going to change the plan and with it the note. But I will confess that it's quite rare that I actually change that note. Usually most of the key work is done in that chart review in advance, and certainly the conversational part of that can happen by phone and by video. So looking forward to the post-COVID-19 era, hopefully sooner than later, I see medicine forever changing for both of these classes of patients. And I see doing a lot more of these, do you have a trial for me, or am I doing the right thing consults via video. Jack, you mentioned earlier the interstate regulations. Those are temporarily dropped. Mm-hmm. But I have some concerns about whether that will remain permanently. Obviously, I think it should. I have some concerns that it might not.
Of course. And you know, you bring up a very good point about our lives and our homes intruding. This is a different dynamic in both directions, because we are now in a telemedicine visit seeing a patient at their homes, and it's a little more familiar. They're seeing us in a different environment, perhaps with, you know, the dog barking, the kids, whatever it is, but they're getting more of a window into our lives than the controlled and synthetic environment of the, you know, the exam room, which is previously where we were.